But on that note, I'd love to introduce our speaker tonight, Dr. Jenny Cook, who's going to talk about endometriosis. Thank you.
And thank you so much for coming tonight. So I'm Dr. Jenny Cook. Jenny, I hope this is still working now. And I'm passionate about treating fertility and endometriosis. I've worked in this space for 25 years, as Heather could attest, if Heather's listening. And thank you so much for coming tonight. And I think this is really just a wonderful group that you've got going on, that you meet on a regular basis like this. So I'm largely based in the Sydney CBD and in Bondi Junction. I'm going to flick through these quickly. Endometriosis is the presence of ectopic endometrium or stroma outside the uterus. It is very common in women with subfertility. And we know that from the time a woman develops symptoms of endometriosis to the time it's definitively diagnosed, it can be up to 12 years. So I see a lot of women who have suffered years of pain before the endometriosis is definitively diagnosed and treated. The cause is largely unknown, but retrograde menstruation is the most popular theory. Do you know, the other thing is, if you had any questions, like I always say to my patients, you can interrupt me at any time and ask anything, but we've got time at the end as well. I've listed here some of the symptoms, but the golden rule is there is no golden rule. Endometriosis doesn't always read the textbook, and can present in a whole multitude of ways. And the group of women that I really worry about, that I think are often overlooked, it's the subfertile group who have no pain. And I see them going through years of unsuccessful IVF cycles before someone says, you've got endometriosis, we should actually have a look inside. Chronic pelvic pain is that which lasts for months to years, and as you can see, it's due to a variety of reasons. Obviously, as a gynecologist, endometriosis will be the most common thing I see. Adenomyosis is where the endometrium migrates out into the muscle layer, and the women end up with just a really bulky, inflamed uterus, and it's the most common benign cause for heavy, painful periods for women in their 40s. An inflamed bladder, interstitial cystitis, pelvic congestion syndrome, neuropathic pain. A lot of these women end up with pelvic floor muscle spasm secondary as part of the picture, so really tight pelvic floor muscles, and chronic PID. So how do we diagnose endometriosis and chronic pelvic pain? Well, obviously a good history is important, a good ultrasound is important, but I stress the vast majority of women I see with endometriosis actually have completely normal imaging. The most accurate, the most informative, non-invasive investigation is called a deep infiltrating endometriosis ultrasound, or a DIE ultrasound. It's performed in specialised ultrasound units by perhaps a gynecologist who's got a subspecialty interest in endometriosis, or perhaps a radiologist. It takes about an hour. The woman has a light bowel prep, and it really does provide a lot of information on what might or might not be going on. The ovaries will be imaged to look for mobility, and lack of mobility would suggest that there's inflammation underneath, such as due to endometriosis. Looking for small cyst endometriomas, which is obviously a cyst due to endometriosis. Looking in the base of the pelvis for normal mobility of the rectum over the posterior part of the uterus, and lack of mobility would suggest an inflammatory process such as endometriosis. Looking for nodules in that area as well. I find this investigation very useful so that I can say to the woman, using a model, this is what's going on, this is what's causing your symptoms, and also in the planning. And you'll see that from some of the cases later on. If they've got full thickness bladder disease or bowel disease, it just means that I can plan that a lot better and give them an expectation about what's required. Okay, I was going to come to that later on, but I'll answer that question. I've been asked, who do I recommend to do them? So they're done by, as I said, subspecialised units. I have looked at the reports that I've been given and looked at actually what was found at laparoscopy, and I can tell you the group that where their reports correlate most closely with what I see is actually Sydney Ultrasound for Women. So that's my answer to that. And I can go through later on and I can tell you exactly where they were done and what was found. Yes, another question.
Is it a GP appropriate
Yeah, yeah. And
something that's more useful for planning for a
no, GPs can absolutely order them. And if a GP has ordered and they come in with it, like I feel like I've got more information to talk to them about it. I love it. I myself wouldn't order it on everyone. I look for what we call pouch of Douglas type symptoms. So I'm going to show you diagrams later on. If they've got sharp shooting rectal pain or deep dyspareunia, I just want to know about bowel involvement. I use it there in the planning, but I love it when women come in with that. Because I love sitting down with the models and explaining this is why you've got these symptoms.
From what age? Because what about teenage girls or
Yeah, so that's a hard one. I go through this later on as well. It's generally considered that for teenagers, you don't go down the pathway of saying this is rip-roaring endometriosis, they need a laparoscopy. You manage that conservatively in the first instance. But with these women or girls, there comes a point where if the pill doesn't work, if the Mirena doesn't work, you have to say to them, we'll do a laparoscopy. A lot of them will have a hymen, so I wouldn't do it in that case. And I'm obviously I can say Sydney Ultrasound for Women are very respectful of that as well. That's a whole extra conversation. I wouldn't get a transvaginal ultrasound done in that situation, if that's what you're asking. Yes.
I'm intrigued by ovarian mobility.
Yes.
I thought men had the mobile parts.
I'll show you later on what I mean. But again, depending on where they go, I think it's 50% accurate. If an ultrasound reports these ovaries are normally mobile, I think it's 50% accurate. If they report that they're adherent to the pelvic sidewall or the uterus, I take into consideration their other symptoms and I think, yeah, that may be the case, but let me have a look inside first and decide. The question was asking about ovarian mobility. That's one of the key things that I look for in those DIE ultrasounds. So to continue, laparoscopy is considered the gold standard for the diagnosis and treatment of endometriosis. Another modality, if they've got bladder symptoms, is a cystoscopy looking for inflammation or interstitial cystitis. Our college has just published guidelines for the management of endometriosis, and I just touched on it here. I would say guidelines are just that, they're guidelines. I cannot overestimate the importance of listening to a patient and individualising management, listening to what her concerns are, listening to what her fertility plans are. I don't strictly adhere to the guidelines. I pay attention to them, but I think about the individual woman. That's just a little side note. And as someone asked before, conservative management is reasonable if there's a normal ultrasound. It's the first, second and third line of management in a teenager. And obviously if a woman requests it, I mean, I can think of women that I've seen who are 44, 45 with minimal symptoms and fertility is not an issue. And they've probably got endometriosis in there, but they don't need an operation. And if they say they want to be managed conservatively, that's perfectly fine. Not everyone needs an operation. But there's no role for the conservative management of if a woman has endometriosis where fertility is concerned. So let's talk a bit more about a laparoscopy. The gold standard, we say, is a definitive, I always say I do a definitive and wide local excision. I do a good pelvic clean out is what I tell the women, of anything obvious and anything subtle. And this is a laparoscopy here, and I was asked before about ovarian mobility. This is a pelvis, and the first thing I see here is that there's just generalised inflammation of all those tissues. That uterosacral ligament is really prominent. That will be white scarred endometriosis. It can have just a subtle generalised appearance. It can be black and pigmented. It can be a subtle powder burn appearance. And that there is the rectum in the pouch of Douglas. And inflammation of that tissue over the top, they will present with sharp-shooting rectal pain. It's generally cyclical sharp-shooting rectal pain. And disease in the uterosacral ligaments, they'll have deep dyspareunia. I know those ovaries are mobile because I can lift them off the side walls. They're not attached to the side walls, they're not attached to the uterosacral ligaments. That's what I mean by normal mobility. And the final image just shows, when I say a definitive wide local excision, I've excised both pelvic side walls, like right from under the ovaries down medially to the uterosacral ligaments. I've excised the uterosacral ligaments, and I've excised the inflamed areas and the pararectal areas from the pouch of Douglas. And I can tell you all of that came back as endometriosis. So now we're going to talk about a few case histories. These are real stories. The first case is a woman, I mean, I'm giving the plot away, I suppose, at the start. It's a bit of a plot spoiler. She's got full thickness bladder endometriosis. This is a 39-year-old woman, a nulliparous woman, who came to see me with excruciating pain with a full bladder. She had pain at other times, but that was really the symptom. And in fact, when she went in for the ultrasound, she said, I had the pain then. And in fact, that was because she was told to have a full bladder. And she said to me, I always ask them about fertility plans, and she said, I'm planning it in 2 years. So the GP ordered the DIE ultrasound, and this is so rare, so uncommon. She's got a full thickness bladder nodule, which is about 25 millimetres. It's so unusual that I thought, I almost don't believe that. So I got a pelvic MRI done, and that confirmed it. We've got the uterus here, the bladder here, and we've got that nodule going out into the bladder. So I spoke to the urologist, and we found a time when we were both so I work at Prince of Wales and at St Luke's. We found a time when we were at Prince of Wales. I did the cystoscopy. There you can see it there, just this bluish tinged nodule. He stented the ureters. Now, in fact, I suppose he was being very thorough, but the lesion was right up at the fundus. It wasn't near the ureteric ostia anyway. The ureters were not going to be an issue, but I think that's what they do, and that was safe. I then did a laparoscopy, which shows that the bladder is tented over the anterior surface of the uterus. Behind that, I've got a left ovary there. I can tell you the ovaries were mobile. She just had diffuse inflammation in the rest of the pelvis, which was endometriosis, but the real problem was her bladder. So he left the theatre and said, I'll just be a couple of theatres down. I mobilised the bladder. I then entered the bladder, and that's a view that you don't see every day of the bladder. That's a catheter and 2 stents. And I've excised the nodule, and then I closed it with 3-OPDS, a watertight closure, and that's the image at the end showing the bladder that's closed. And then I went in behind and excised the pelvic sidewalls and the pouch of Douglas. And then I went back to him and said, it's fine, it's finished. And he said, well, you just drain it for 12 days. So I did remove the catheter after 12 days. She had minor urgency that resolved, and everything was fine. But if I look back at this case, I really should have said to her at that point, we need to talk about fertility. But I think what had happened was she'd had a big procedure and was quite overwhelmed by that and just needed time to get that, to get over that, I suppose. If she'd done embryo freezing at that point, that would have been the perfect thing to do. Embryo freezing is it's the first 2 weeks of an IVF cycle. She had a partner stimulate the ovaries, collect the eggs, store the embryos. So I work with Monash. They've got a state-of-the-art lab. It's amazing, and a great genetics department. And I would have said to her, get the embryos genetically screened so that I can give you the greatest guarantee that you've got a viable embryo there for later on. But what ended up happening was she came back 4 years later when she was 43, and she'd been trying for 12 months. The pain had completely gone, which is wonderful. And she said, but her AMH has gone down to 1, and up here she had good ovarian reserve at 39. And I had to be very honest up front and pragmatic, and I said, the chances of for any woman conceiving at 43 is about 5%, but she said, I want to try. So I supported her through a few unsuccessful cycles, and then I talked to her about donor eggs, and she's still considering that as an option, but I really don't think she's going to go ahead with that. Yes? AMH is not, I always say it's not the new black of fertility. Everything you do paints a picture. Your fertility is driven by your age, and if your AMH is 1 or 2 or 10 and you're 43, the term pregnancy rate is 5%. but you may be that 5% if you've got a decent AMH. That's how I would explain it. A low AMH will bring out a group of women who are more likely to need intervention and who might ultimately never have a successful term pregnancy. It paints a picture. It's got a role. When I see 43 with an AMH of 1, I think this may not work. If I see AMH of, I don't know, 8, I think you might be that 5% where it works. This case is a case of stage 2 endometriosis in a woman who wanted a tubal reversal. So this is a 35-year-old woman who came over from South Australia. She'd had 3 pregnancies easily delivered by caesarean section, but there was domestic violence in that relationship, and that becomes very important later on. Her mother, at the time of the final caesarean, was very... She said she forced me to have my tubes tied, and she said, I carry that as a scar every day. A scar of the fact that I can't have a baby, a reminder of that relationship. She did end up meeting someone else and she wanted to have a baby. So she came to see me and said, I've actually developed quite a lot of pain. She's got pouch of Douglas symptoms. She's got dyspareunia and cyclical rectal pain and really bad dysmenorrhea. It was really quite incapacitating. So I got a DIE scan done over in Adelaide and it came back with no nodules, but I knew that she had superficial endometriosis. It won't pick that up. The other fertility investigations were normal. So I said to her, we'll do a laparoscopy, we'll excise the endometriosis and we'll reverse the tubes, but this is what you need to know. There's a risk you might need to do IVF because you're 37. There's a risk that you might get an ectopic, a risk that I maybe can't reverse it, or a risk that it's reversed but then re-stenoses. So this is it. The second image there is just showing the 2 ends, and I cut the ends so that they bleed and I know that I've got viable tissue. And then I suture them with fine 4O PDS. And that's the left tube. I do the same on the right. And that's what the pelvis looks like at the end. But in behind that, she had inflammation. So this final picture shows the cut edge, showing that I've excised both side walls and the pouch of Douglas. She came back in, and in fact the endometriosis was only in the pouch of Douglas and the right side wall. That's stage 2. I thought she'd have stage 4, but she didn't. She moved to Queensland, and I said, you have to wait 3 months for the tubes to heal before you start trying. I contacted her just recently, and she's been trying for 12 months. Clearly at least one tube is open because she's had chemical pregnancies, but I think she's going to be seeing me in the near future to talk about IVF, and I think she may travel down from Queensland. What this history points out, I think, is the issue of pain, which is multifactorial. It was the endometriosis, but I believe that the domestic violence actually played into her presentation in a very real and significant way, and that's not an isolated case. The next one is an interesting one of endometriosis and fibroids. So this woman came to see me when she was 37. She was single and said, I want to freeze my eggs. I've got no symptoms, regular cycle, no pain. And you can see all her investigations are good. She's got good ovarian reserve, but the ultrasound showed a lot of little fibroids. The largest was 37 millimetres, not considered clinically significant. So we did egg freezing, and I'm a big fan of egg freezing. It really is a viable option for young women to preserve fertility. I say it's a good insurance policy, it's not a guarantee. She then came back to see me 4 years later with a partner and said, we're planning on having a baby, but I've really got a lot of pain now. I've got pelvic pressure, period pain, cyclical rectal pain, you can read them all, periovulatory pain, but she's got urinary frequency, like from a lot of pressure on her bladder. Now, I didn't do a DIE scan because I question how accurate it would be with the large fibroids anyway. The fibroids had really grown in 4 years. She's got 5 fibroids, a 49 millimetre one abutting the endometrium and 4 others going up to 85 millimetres. So fibroids, I think that fibroids are undertreated. I hate them, and I think the ones that are clinically relevant, they need to go. I don't remove all of them, but what I say to a woman is the ones that will have a negative impact on fertility would be if they're greater than 10 centimetres, if they're distorting the cavity, if they're going through to the cavity. But I think you also have to think about the pregnancy. They can grow in a pregnancy, they can degenerate, they can cause pain associated with preterm labour and a risk of postpartum hemorrhage. These were certainly big enough to cause a problem, and this woman needs everything on her side because she said to me, I want to put this off till I'm 42. And I said, I always say to women, I can give you the best advice in terms of your fertility and maximising everything, but you have to take what I say in the context of the rest of your life. And she said, we want to wait till I'm 42. So she's got, I can tell you her mother was there, and she said, really, darling, we're talking about your fertility. And I thought, listen to your mother. So this woman's she's 41, she's got fibroids and endometriosis, both of which are symptomatic and both of which have a negative impact on fertility. So we had a good talk about what I would do. I did a laparoscopy, and this is just a multifibroid uterus. That's the 85 millimetre one at the fundus. But then I looked in at the sidewalls and in behind, and you can see she's got black pigmented, red inflamed endometriosis, but I couldn't get in there to get rid of it because the fibroids were in the way. And I talked to her about this beforehand. I let the gas out. I did a laparotomy. I got rid of the fibroids in the uterus, sutured the uterus up, closed the laparotomy, then put the gas back in again. And now I can see black and red inflamed endometriosis on the right side wall, and I can remove it. That's removing the inflamed area of the left side wall. This is the pouch of Douglas. That's what it looks like at the end, and that's showing a normal uterus, normal size uterus at the end, and the fluid going in as an adhesion barrier just to stop any adhesions. So the pathology showed fibroids weighing up to 275 grams, endometriosis in all specimens. I did all the fertility investigations. I said, you need to be proactive. You'll have to wait 3 months for the uterus to heal before you'll carry a pregnancy. But I just think the golden light on the horizon for her is that she's got 10 eggs in storage from when she was 37. And this woman, I believe, will have a term intrauterine pregnancy with her own eggs. So the next one is stage 4 endometriosis. This is a 27-year-old nulliparous woman who's been trying for 4 years. Her endometriosis did actually read the textbook. That's classic presentation of endometriosis with premenstrual spotting as well. And every other investigation is normal. She's got her partner has normal semen analysis and a normal AMH. She went to see someone else who did an IVF cycle. She had one non-viable pregnancy, and he said, this is unexplained infertility, let's do it again. And I just say, no way, this is absolutely endometriosis. So she came to see me, and I said, well, clearly we're going to do a laparoscopy and look inside. And of course she had endometriosis. There's 2 normal mobile ovaries, but what I can see here is that's a uterosacral ligament, which is really scarred. That's the pouch, that's the rectum just there, and she's got inflamed tissue there, which explains her rectal pain. That's the left side wall with red inflamed, white scarred endometriosis. And the other thing that I can see here is just general inflammation of the right side wall, and again, the scarred uterosacral ligaments. So, it was on the bladder as well. She's got black pigmented endometriosis on the surface of the bladder, not full thickness, just sitting on the bladder. So I excised the left side wall, I excised it off the bladder, I excised it from the pelvic sidewalls and the base of the pelvis. It all came back as endometriosis, and guess what? She fell pregnant the next month, and she's now got a 6-week-old baby. So that's a good story. What I would say here is to remove endometriosis in the right situation, obviously, it's like the gift that keeps giving. She's set up now to have a second baby rather than having more IVF, which is going to make her pain and endometriosis worse. And in a young woman who's got a history like that, it's not unexplained. I don't even know that young women with normal ovarian reserve actually have unexplained infertility. I think endometriosis is underdiagnosed. So the next one is bowel endometriosis. This is a 29-year-old nulliparous woman who's been trying for 3 years. I can say her endometriosis didn't read the textbook. She had premenstrual spotting and period pain. Regular cycles, a good AMH. She did not have a DIE ultrasound, which I wouldn't have been prompted to do it because she didn't have bowel symptoms, but that would have given us the answer. She went to see someone else and did one IVF cycle and got 2 embryos, and it didn't work, and she was told, this is unexplained, let's do it again. So she came to see me and said, can we do a laparoscopy? And I'll just push on through this. It's that first image is what I saw. I thought she'd have widespread, she'd both mobile ovaries. I didn't predict she was going to have a big nodule of rectum there with a mid-rectal nodule and black pigmented endometriosis of the right uterosacral ligament. I excised everything except obviously that needs a bowel resection. So I got her to see the colorectal. She really didn't want to do more IVF. Her estrogen had gone very high. She hyperstimulated. She just really didn't like it. So they planned for a bowel resection, and there was a large, as I've said, a large rectal nodule involving the urosacral ligament, a mid-rectal nodule. She had a low anterior resection, and the final image is a primary anastomosis. She was discharged on day 3 and attempted a pregnancy, but it didn't work after 5 months. So she came back to see me, and this is 3 years after the first cycle. She has had the endometriosis removed. 3 years ago, she got 2 blastocysts. I did it with low-dose stimulation, and she got 7. And I did an embryo transfer, and she was pregnant, which is a good outcome. But what do we learn from this one? So the question I ask is, what is the evidence for treating endometriosis like this before you do IVF? We looked to ESHRE, the European Society of Human Reproduction Endocrinology. We looked to their guidelines. There's no evidence for doing it. No evidence that if you remove endometriosis, it improves your IVF outcome. It doesn't mean that it doesn't. It just means there's no evidence. So again, I would say you need to listen to the woman to individualise the plan. She didn't want to do more IVF, but often these women suffer pain, and that is what really prompts surgical intervention. So the final one of the fertility cases is a woman with bilateral endometrioma, just really large cysts of the ovaries. She was 36. She'd been trying for 12 months. Her endometriosis didn't read the textbook. She had no pain at any time. She just felt like she had a pelvic mass there. She in fact thought it was fibroids. Her GP organised a very good quality DIE ultrasound, which showed 20 centimetres worth of endometrioma across 2 ovaries. You can see on the right, the largest was 10.5. On the left, it was 8.2. The perirectal tissue is tethered. That's what it means when it says the pouch of Douglas is obliterated, but she didn't have any full thickness disease. But the other thing that's interesting here is they could see 3 follicles. Her antral follicle count was 3. Her AMH is 20.8. 3 is low. 20.8 is normal. So I would just conclude that the eggs are there, but they can't see it on ultrasound because the endometrioma is obscuring it. And whatever we're going to do, we need to get rid of those endometrioma. So I talked to her about a laparoscopy, and if you're talking about doing something to a woman's ovaries, I said to her, I respect ovaries, I work in fertility, I do endometriosis, I know how to preserve normal ovarian tissue, there's a way to do it. So there's the images there on the ultrasound. This is the laparoscopy. These were huge. They were going 2/3 of the way up to the umbilicus, and that's what kissing ovaries are. They were actually adherent to each other. So I decompressed it, and it's all that chocolate fluid that comes out. What I'm doing there is stripping out the endometrium and being very careful to preserve normal ovarian tissue, but then you're left with like this floppy, empty balloon. So and that was on both of them, so I sutured them to encourage healing and reorganisation of the tissue. But then I came across this here, which is a hydrosalpinx, which I wasn't expecting. The inflammatory process of the endometriosis has obstructed the fimbria and the tube's filled up with fluid. It's known that if you remove a hydrosalpinx, you actually confer a positive impact on a woman's ongoing intrauterine pregnancy rate, both naturally and with IVF. So that's detrimental to her fertility. It's not working. The theory is that it spontaneously discharges fluid into the uterus and flushes out an embryo. And it's often a difficult conversation to have. You would think you're better off having 2 tubes, but you're actually better off having 1 tube and getting rid of one that's non-functional. So I removed it, and also the endometriosis in the base of the pelvis, and that's the image at the end. You can actually see the uterus now, and I'm just putting in an adhesion barrier there. So, yes, question. Yeah. It does. So The only way to minimise adhesions is to do it slowly and to be as dry as you can. I suppose that's what I have to say. So I do a good irrigation. I keep going till it's as dry as it can be. But you can use agents like tranexamic acid to minimise the risk of it. But I know that there are cases where it probably continues to ooze. I don't know that we've ever got the perfect adhesion barrier, but I am always thinking about adhesions. I think Adept is as good as what we've had. I've seen over the years many different agents that have been used. Adept is, well, you can see it looks like water. It actually sloshes around in the pelvis for about 48 hours and then I think it keeps the surfaces separate while the peritoneal surfaces are healing. Probably the only way to know would be to do a second look laparoscopy after 2 or 3 weeks, and I just don't know that you could get all women to commit to that. Adhesions are a problem. That's my best answer. There's a way to minimise the risk of them, but I don't think you can do that 100%. Omentum doesn't seem to be so much of a problem. Omentum is definitely a problem with an appendix. I have got a case coming up later on of a woman who definitely had bleeding post-operatively, and you can see what happened there. The times that a woman has come back in and it appears that she's got recurrent endometriosis, the ovaries tend to stick down, but I don't see omentum. I can't even say that I see a lot of bowel adhesions, but I suppose that happens. The ovaries do stick down on the side. Well, not 100%, but it happens, yeah. So the pathology showed endometriosis in all specimens, including the left tube. She tried for 6 months and it didn't work. She came back and said, we're going to have to do IVF. So this is interesting. After 6 months, the ultrasound actually gave me an antral follicle count of 9 compared to 3 preoperatively. Now, I didn't give her eggs. It just, I think, confirms what I thought was happening to start off with. The endometrioma obscuring the normal ovarian tissue. So I did one cycle, we call it antagonist cycle. I got 5 eggs, the embryos stopped dividing and I didn't do a transfer. But I said to her, you're in your 30s, you've got a 3 in front of your age, an intervention, we should get you pregnant, you've got to keep going. And I gave her a lot of support. There's some evidence for DHEA, coenzyme Q10, niacinamide and melatonin. It's not 100%, but I said, look, try these supplements. It may help with egg quality. And I did a second cycle. I got 9 eggs, which actually corresponds to the antral follicle count of 9. And I got 2 grade 1 embryos. And she is pregnant, and she's going to have a baby in December. But the question I ask is, what's the evidence for removing an endometrium before IVF? And ESHRA says nothing. There's no evidence that it'll improve the outcome for an endometrioma greater than 3 centimetres. But again, you have to individualise management. I wasn't going to be able to collect those eggs. I believe she would have ended up with a pelvic abscess if I'd needled those endometrioma at IVF. But you absolutely need to counsel them about the risk of loss of ovarian reserve. Now, pain. So the first case is a 22-year-old nulliparous woman who was actually living in Salzburg. She had extraordinary pain, daily generalised pelvic pain, pain worse from the time of ovulation for the first 3 days of her periods, numerous presentations to A&E, acyclical sharpshooting pains, nausea, bladder-related symptoms. She was on a range of medications, including on Dancitron for the nausea. She had an interesting history. She'd just been diagnosed with right hip bursitis and was seeing a physiotherapist. She was born with a bilateral cleft palate, and I just think had seen a lot of doctors over the years. She'd needed numerous surgeries and had chronic sinusitis and needed frequent antibiotics, but also particularly relevant, she had a history of sexual assault. And I'll just say again, I believe this plays out into the lives of these women and their pain in a very significant way. And I don't think you'll find this published anywhere, but when I look at the women I see with difficult to manage multifactorial chronic pelvic pain, I think 95% of them have either had some history of domestic violence or sexual assault. I got her to have a DIE ultrasound because of the rectal symptoms, but this was done closer to her home, and there was aspects of this that weren't correct. They reported the left ovary was adherent to the left uterosacral ligament, which it wasn't, and I'll show you. They reported loculated fluid in the sidewall, which wasn't there. I talked to her about a laparoscopy with definitive excision of endometriosis, putting in a marina and a cystoscopy. And this is what I found. The ovaries are sitting up out of the field. That's a right ovary just there. That's the uterosacral ligament. The left ovary is not adherent to it. But what I see is just generalised inflammation, really prominent uterosacral ligaments, particularly that right one, and an inflammation of the tissue over the pararectal tissue and the pouch of Douglas. So you can see in the final image, I did a wide local excision. Cystoscopy was normal. I put in a marina. It all came back as endometriosis. Her pain did get better for a while, but I'll go through and explain. There's really multifactorial pain, and she continues to have pain. She, in fact, moved back home, and I've seen her recently, and her GP is excellent. And I just, whilst I'd say it takes a village to raise a child, I think it takes a village to manage a woman with chronic pelvic pain with an excellent GP at the helm. Her GP had a good understanding of the medications that she was on. She was looking for any loose ends and making appropriate referrals. So the marina is known to cause recurrent cysts, and these were incredibly painful for her. And I think what had happened was she'd had chronic pain for so long, her nerves had been sensitised that anything that happened, like a 2-centimetre cyst, was exquisitely painful. So the marina was removed, and I suggested the continuous pill. Well, the cyst persisted, and she had breakthrough bleeding, so that was discontinued. She, in fact, said to me, would you consider a further laparoscopy? And my answer is no, I wouldn't at the moment. I'm not saying no, never. But I said, you've got a lot of loose ends at the moment. This is a young woman with multifactorial pain. She has probably developed pelvic floor muscle spasms, so I've made sure she's seeing a good physiotherapist. She's on a waiting list for a chronic pain clinic. She's got ongoing sinus infections. She's developed pain when she eats, so the GP has got her to see a gastroenterologist. She's got chronic fatigue. She's seeing a neurologist. When I saw her, she was doing a 24-hour Holter monitor because she'd had dizziness when she stood, and there was a suggestion of POTS. The hip bursitis had resolved, but I just say the psychological aspect cannot be underestimated. This woman is really, her whole life, she's moved from Salzburg back home. It's really impacted by her pain, and the sexual assault cannot be underestimated. This is another woman with chronic pelvic pain. It's a 33-year-old woman with a history of endometriosis. I never saw the reports of those laparoscopies. She had 3 pregnancies conceived easily, delivered by caesarean section. She had ongoing pain after this. This was before I saw her. 4 years before I saw her, she had a complicated open hysterectomy. It apparently took 4 hours. I mean, it should take 60 to 90 minutes. So that was, something happened, and I never got the reports of that. But that really triggered her pain. She's also had 3 DVTs, which becomes quite relevant later on. And I did the thrombophilia workup, and she doesn't actually have any a defined thrombophilia. So she came to see me and said the pain is absolutely worse since that hysterectomy in 2021. I've got bad left-sided pain, sharp shooting pain, PR bleeding. She kept saying there was worse on the left. She was on Palexia, and she also knew that she had pelvic floor muscle spasm, and in fact got relief out of PR Valium. She probably was. I did actually get her to see a colorectal. I haven't put that in the history. She probably was. And constipation is obviously a part of this as well. I got her to have a DIE ultrasound that was done closer to her home. And parts of that were misleading. So it talked about bilateral endometrioma, which was actually inaccurate. At that size, 10 millimetres, you could never accurately define what sort of cyst it is. It said the left ovary was tethered to the bowel, which was absolutely correct. It reported nodules of endometriosis, which was not correct. I got her to see a colorectal because of all those symptoms, and because of all those symptoms and because of the endometriosis. The discussion was that they wanted to avoid a bowel resection in the first instance. He booked her for a colonoscopy because of the bleeding, but it was postponed because she ended up with COVID. So I consented her for a laparoscopy, and she said, I want you to remove the left ovary. I've got so much pain there. And I said I would do that. I said there was the possibility of full thickness bowel disease and she might need a second procedure later. And she understood all of that. She just had a pelvis full of adhesions. And when I look back, I think she had a bleed. So this is my point about bleeding and the importance of hemostasis. I think she had a bleed after the hysterectomy, which was managed conservatively, probably over several months. They are mental adhesions. I had to divide all those before I got down to the pelvis. That's the right ovary. That's an mental adhesion on that. It's not bowel, but the left ovary over there was the problem. The rectosigmoid was morbidly adherent to that, and so I carefully dissected that off with sharp dissection. I removed the ovary, which was actually a reasonable thing because the adhesions could come back. But there you can see no adhesions. The right ovary is mobile. I'm putting in an adhesion barrier again. There's actually a 2 centimetre cyst on that ovary, which becomes relevant later. There was no endometriosis at all. This was a post-operative adhesions related to a hematoma, I believe. A luteinized follicle of the left ovary. It wasn't an endometrium at all. And she came back and said, I feel 900 times better. But the story goes on. So she's got multifactorial pain. She's had endometriosis. She's got adhesions. She has continued to have ovulation-related pain on the right side. And as I said before, I think in these women with chronic pain, their nerves become sensitized, and ovulation or a small cyst, for someone else might not be painful, but for them it's exquisitely painful. Lyrica was no benefit for her. She's got ongoing pelvic floor muscle spasm, which is being addressed. But then she has just recently said to me, you know, there's been domestic violence and the relationship has ended. And I just say again, this plays out into the lives of these women in a really very significant way. This woman continues to have really severe sharp-shooting right-sided pain, which is cyclical. It must be ovulation related. She asked me to remove her right ovary, but I'm really not going to do that because then I have to think about HRT and she's a DVT risk. So it's a work in progress, but other options to block ovulation might be the progesterone-only pill. And then the final case is one of chronic pain due to endometriosis. So this is a 27-year-old woman who initially had severe premenstrual cramps. She tried several pills but got mood swings and anxiety, so they were discontinued. She came to see me with a Mirena, but she still had episodes of crippling pain, a regular cycle, mild dysmenorrhea, and significant PMS. It was really a problem to her during menstruation. She just felt really down. The ultrasound was in fact misleading. It reported a 9mm loculated fluid in the left adnexus, so I got her to have a DIE ultrasound, and that was at Sydney Ultrasound for Women. And in fact, that was just a red herring. It was a parafimbral cyst, which is just an incidental finding. But it reported the left ovary was tethered to the sidewall, which was absolutely correct. And that was really what made me think you've got endometriosis going on. So I talked to her about a laparoscopy with wide local excision and change of Mirena. And this is what I found. That's the left pelvic brim. So she's got black pigmented endometriosis, which I'm removing in the third picture. The second image, the left ovary is really adherent to the sidewall. So I mobilised that. There was actually endometriosis in the left mesosalpinx, which is just a really vascular area of the left tube. I removed all the endometriosis underneath. There was inflammation on the right sidewall and pouch of Douglas, which I removed. I changed the Mirena over. There was endometriosis in all specimens, and she came back to see me and said, well, I've still got mild dysmenorrhea, but it's controlled. I've got ongoing periovulatory pain, which is better, and my PMS is better, but it's still there. She now actually had it during ovulation and during menstruation. So the summary, the takeaway messages, guidelines are just guidelines. You need to individualise management. Listen to a woman's fertility plans. Listen to an individual woman. There's no role for conservative management of endometriosis as far as fertility goes. If a young woman is told she's got unexplained fertility, infertility, always question that because she may very well have endometriosis. I've stressed that a GP has a critical role in the management of a woman with chronic pelvic pain. And in that woman with chronic pelvic pain, always think about asking about sexual assault. So thank you for your attention. Thank you.